All right. Hello, good morning, everyone. Hi, I'm very pleased to introduce this morning Dr. Justin Jordan. Dr. Jordan is a national leader in neurofibromatosis clinical care and research. He is an associate professor of neurology at Harvard Medical School. He is the clinical director for neuro-oncology. He serves as the director of the Family Center for Neurofibromatosis at Mass General Hospital. In addition to his clinical and academic work, he leads multiple educational forums for patients and families affected by NF and is a perennial volunteer for patient advocacy organizations. Dr. Jordan serves as a member of the Children's Tumor Foundation Clinical Care Advisory Board. He's chair of the Scientific Advisory Board of Neurofibromatosis Network. He's a member of the Board of Directors for Neurofibromatosis Northeast, and he was a co-organizer of the 2024 Global Neurofibromatosis Conference. And we're very delighted to welcome Dr. Jordan to speak to us today about NF1.
Thank you very much. I really appreciate the invitation to come today. So I'm excited to talk to you about NF. This is the disclosure slide for the course and for my talk specifically. None of this will impact the discussion today. So what I hope to do is update you on the diagnostics of NF1 and a lot about therapies. And it's a little unfair that I'm giving this talk because NF1 has been around for decades, more than 100 years, with very little advance in terms of therapeutics. And now, as a relative newbie to the field, there's such an explosion that I'm excited to talk to you about. So we'll go through an update in diagnostics, talk about Plexiform neurofibroma specifically, which has been really the nidus of some of the therapeutic advances, and then review some novel therapeutics for other tumor types, and finally talk about some guideline-driven care. So in terms of NF1 epidemiology, I think you all know this is an autosomal dominant disorder, but interestingly, about half of people are the first in their family. And so that means that there's a lot of mosaic disease where patients are segmentally impacted by a mutation in the NF1 gene that may cause part of their body, but not their whole body to be impacted. We do believe that NF1 is 100% penetrant, meaning that if you carry the pathogenic variant in the germline, you will have a clinical manifestation. The incidence is about 1 in 2,300 to 1 in 4,000 live births. That's based on several studies in the UK and Finland, and really an exceptionally common rare disorder, if you'll allow that. And the median lifespan for NF1 is about 71 years. So although abbreviated compared to population average, not tremendously. Now, NF1, the gene, is a RAS gap pathway regulator, and specifically regulates both downstream RAF and PI3 kinase, as well as others, and so is involved in both cell growth and cell cycle regulation and cell survival. And you can see that there's this balance between proliferation and stemness and differentiation and senescence, that when NF1's protein product, neurofibromin, is functioning normally, RAS is able to easily swing back and forth between GDP and GTP state and keep that delicate balance. But in the absence of neurofibromin correctly functioning, it is often the case that we lean more into the proliferation and stemness component of normal cell cycles, and that's especially affecting the neural crest lineages of cells. Now, as we've looked over the years at the genetic abnormalities or pathogenic variants for individuals affected by NF1, there's enormous numbers of variant locations and types. It's very heterogeneous. And so you can see from these couple of graphics, just the huge number of individual variants that have been categorized, including whole gene deletions, as well as each of these sort of smaller events. And this from a study published last year shows the variety of different types of pathogenic variants, all the way from nonsense and missense to whole gene deletions and splice site mutations. With this large variety of pathogenic variants, using current technology and NGS, we're still able to pick up more than 95% of individuals' causative pathogenic variant. So the genetic testing is actually incredibly helpful in that regard. Now, perhaps not surprisingly, with the huge heterogeneity of pathogenic variants, there's actually not many genotype-phenotype correlations that have been identified. And this is a relatively recent graphic just showing the incredibly small number of published genotype-phenotype correlations. Compare this or extrapolate from this in a given family that has multiple generations carrying obviously the same pathogenic variant, the clinical phenotype can be remarkably different. Some with very few tumors and a normal life expectancy, others with malignancies early on and early death. And so it's really been a little perplexing to the field to try to understand that. Our current thinking is that there's probably a large amount of environmental factors and exposures that impact phenotypic outcome, as well as pseudogenes that represent some additional function similar to neurofibroma expression. The diagnostic criteria for NF1 were first formalized really in the 1980s with a consensus conference and were purely clinical. And in 2021, an updated diagnostic rubric was published and looked back at the prior diagnostic criteria compared to current state of understanding with the advent and increased use of genetic testing in the clinics, and really found that the vast majority of the clinical criteria that had been stood up 20 plus years ago held perfectly well. So the people we've been calling as diagnosing with NF1 for 20 years still have NF1, even with the inclusion of genetic testing. So the main updates were essentially just a few additions, which were very helpful. So I think many of you in the room probably know about the importance of cafe au lait macules, the oval-shaped brown spots that we see on the skin of individuals, freckles where the sun doesn't shine, which is representative of the neurocrest lineage of the melanocytes that are abnormally expressed in those locations. Neurofibromas, we'll talk a lot about here in a little bit, are one of the diagnostic criteria. We've known about Lish nodules, which are pigmented hamartomas on the surface of the iris, but newly identified were these bright patchy nodules that are picked up primarily on OCT back in the choroid that are now a part of the diagnostic criteria. Optic pathway glioma, we'll talk about briefly, is one of the longstanding diagnostic criteria. Some long bone abnormalities, including things like tibial pseudoarthrosis related to abnormal formation of the bones, sphenoid wing dysplasia, which is often underlying plexiform neurofibromas where the bones don't form normally. And then newly, and probably most importantly in sort of day-to-day clinical use, the inclusion of genetic testing is now part of the diagnostic criteria. So if a patient has a heterozygous pathogenic NF1 variant in about 50% of their alleles, then that is now counted as one of the diagnostic criteria. Now, importantly, in the day and age of broad screening, you have a new breast cancer, you're going to get a panel of 80 plus genes. Many people are identified as carrying an NF1 pathogenic variant, either in a mosaic form or in their germline, but that alone is not sufficient to diagnose NF1. You have to have a clinical manifestation as well. The last change is in the previous iteration, we had always allowed for a first-degree relative with NF1, but because of gamete mosaicism, now it is specifically a child of a parent with NF1 that would allow for that. Okay, so we talked about some of the diagnostic criteria. The phenotype really evolves over the lifetime, which is a pretty interesting phenomenon. And so we can see in the newborn nursery for many people, some of the earliest manifestations, including the cafe au lait macules. Sometimes the plexiform neurofibromas are apparent very early on in the first year or two of life. We'll talk about those in a few minutes. Some of the bony abnormalities can be present relatively early on, but you don't end up with some of the additional manifestations until a little bit later. So mid-childhood individuals may develop learning deficits. ADHD is exceptionally common, about a 70% prevalence of some amount of learning disability for individuals with NF1. There's often motor and speech delays aligned with that, and optic pathway gliomas tend to arise in young childhood. Later in adolescence, we begin to really pick up on the skin fold freckling, maybe there early on, but certainly by the time they're 7 or 8, you'll see this. Lish nodules are identified. Scoliosis turns out to be an incredibly common problem for which children should be screened at least annually, and adults according to guidelines. Notice that the neurofibromas, the namesake of the disease, may start in adolescence, but in fact, I'll show you some natural history, probably even a little bit later than that for most people. So it's not the earliest of findings. And then lastly, in adulthood, we really get to the world of a lot of cancers. And that is primarily malignant peripheral nerve sheath tumor, the leading cause of death for individuals with NF1, as well as breast cancer and high-grade gliomas. So this is a graphic from over 20 years ago, but looking at the previous iteration of the diagnostic criteria, but recognizing that 2 or more diagnostic criteria are required to confirm somebody's diagnosis of NF1. This group said, well, when can you identify that number? So if you look at the legend over here, the diamonds at the top are 2 or more diagnostic criteria, circles are 3 or more, squares are 4 or more, triangles are 5 or more. So these people are expressing the disease enough to be officially diagnosed. And you can see that before 1 year of life, 70% of individuals have 2 or more diagnostic criteria and are diagnosable. So children are often diagnosed in the newborn nursery. Now, obviously, that's slanted toward people born to a parent with an F1, where they get that diagnostic criterion. But as we go on, usually by the time a child is 4 years old, more than 90% are diagnosable in the clinic without genetic testing based on this data set. So the clinical phenotype and the clinical examination is so critical in those early years to identify these individuals. We'll talk about some of the tumors in a moment, but just for the trainees in the room, a few pictures of cafe au lait macules, which are relatively smooth bordered oblong hyperpigmented macules. These are some of the abnormal freckling you can see in the armpits. The same can happen in the inguinal canal. These are a few pictures of the recently added choroidal abnormalities that can be picked up on OCT and sometimes with fundus photography, where you can see this. And Dr. Stemmer Rahamimov, one of our neuropathologists, has looked at these, and they do have a neural crest component similar to the cafe au lait macules and so forth. This is a picture of some of the Lish nodules that can be picked up on the iris. And then lastly, a couple of the bony abnormalities. This is an X-ray of a child's legs with pseudoarthrosis. This really develops primarily because of abnormal formation of the long bones. And then as the child begins to bear weight, they develop small microfractures that accumulate and can develop this false joint. Lastly, this is a sphenoid wing dysplasia in this individual. And as I mentioned before, you can tell that although not universal, it is often the case that there's overlying soft tissue tumor, such as a plexiform neurofibroma that may impact the bony formation there. So I'm going to talk to you next about plexiform neurofibromas, which is really a prevalent and morbid component of individuals' experiences with NF1. So undoubtedly, this is one of the leading causes of morbidity and disfigurement for individuals with NF1. You can see a couple examples here on the side of both an MR and a gross photograph looking at the disfigurement that this is causing. And in clinic, in some textbooks, the idea of bag of worms has been used. You can feel sometimes the cords within the tumor like this. Depending on location, there's a wide variety of clinical manifestations. In addition to disfigurement, many of these arise in major nerves and/or brachial or lumbosacral plexus, and so may be associated with weakness or numbness. Those that are in the chest may be associated with respiratory difficulty. In the eye, as I showed you in the last CAT scan, visual impairment, dysphagia, vascular compromise, not surprisingly for those near the large vessels like this in the neck. And because of the adjacency to large vessels and brachial plexus, lumbosacral plexus, and various other critical formations, complete resection is very rarely feasible for these. And so we will see patients sometimes in our clinic who develop the tumor in youth, and by the time they make it to us have had 7, 8 surgeries, all incomplete debulkings. And so this has been the longstanding state of plexiform neurofibroma care, with just many surgeries across the lifetime as they regrow. Pathologically, plexiform neurofibromas are defined as involving multiple nerve fascicles, each surrounded by a perineurium. You can see in this cartoon that in addition to the Schwann cells and the internal neurons, there's actually a large central component of mast cells. And in fact, when we look microscopically at these tumors, the inflammatory microenvironment is just incredibly active. And there's a lot of discussion as to the role of mast cells in tumor growth. As we all know, with mast cell histamine production, additional mast cells are often invited to join the microenvironment and sort of spread the inflammation. So this component is really being sussed out, but you can see that additionally, fibroblasts play an important part, macrophages. It's the microenvironment is quite rich. It's not just purely the Schwann cells. Now, growth patterns have been studied in a few different longitudinal studies and seem to vary across the lifetime. Data out of the NCI for pediatrics shows that probably growth is highest before puberty and then tends to reduce for individuals who are post-pubertal. Now, obviously, there are some outliers in their data set, but by and large, the clinical experience and the natural history data we have suggests that kids are at the highest risk for growth. Trajectory tends to reduce after they get past puberty. In adults, this is also data from the NCI. You can see that the further out you get, the lower the change in volume per year in terms of age. So although there are certainly some adults who do experience growing tumors, we think that it is not as common as children who experience a lot of growing tumors. Now, in that data set, there's also this idea of distinct nodular lesions. The NCI sort of coined this term and idea, and you can see a couple examples here. These are radiographically defined, well demarcated. They look like they're encapsulated. They meet a certain size criterion, and they may be within a plexiform neurofibroma, like this one on the top left, or they may be isolated and separate here. And the NCI posited, based on their data set, that distinct nodular lesions tend to grow up to twice as fast per year as plexiform neurofibromas that do not include distinct nodular lesions. So this really invited an opportunity for the MGH clinic, which has a very large adult population, to look at this. And so Scott Plotkin, about 12, 14 years ago, ran a whole body MRI study looking at about 100 individuals with NF1 to really be a pioneer in characterizing the internal tumor burden and size and so forth for individuals with NF1. And so we then sought to follow up with the same people who had had whole body MRIs and scan them again. For that study, it was 47 adults were willing to come back a second time 10 years later and have another whole body MRI. The median age at that time was 42 for their first scan, 52 for their second scan, and about 10.4 years median between scans. So this is a unique population relative to the NCI, which has studied primarily children and young adults. And interestingly, in our study, we looked at 324 internal tumors and identified that 65% of them shrank spontaneously over the course of 10 years, compared to the large number of actual growing tumors in children and young adults. Now, we did see that 17% grew, so there certainly was some amount of continued growth. And as we looked separately at that topic of distinct nodular lesions, which the NCI had previously identified as a high-risk tumor type for growth, we similarly found that the majority shrank over time in older adults. So as I mentioned, the growth trajectory of plexiform neurofibromas seems to be very impacted by age. And probably the older you get, the less likely you are for tumor growth. Without a doubt, there are individuals who don't fit that paradigm, who have continued growth well into late adulthood with progressive disfigurement and dysfunction and so forth. And so continues to be a population of individuals with a huge need for treating these tumors. Now, I showed you this top left graphic once before. NF1 is in charge of RAS function and therefore is upstream of both RAF and PI3 kinase pathways. And so in the context of MEK inhibitor development for GU, GI, gynecologic cancers, and many ongoing studies back in 2011, let's say, and earlier, Nancy Ratner's group began to think about using that type of medication in plexiform neurofibromas and NF1-associated tumors. And so the first thing that they looked at was just phospho-ERK expression, which is downstream of MEK, that is the function of MEK in that pathway, and treating human malignant peripheral nerve sheath tumor xenografts with mirdametinib, a MEK inhibitor. They identified near complete resolution of phospho-ERK at 5 and 6 hours, but with return at 24 hours, so that it's temporary reduction in pathway activity there. So then they used mice who had growing MPNSTs, malignant peripheral nerve sheath tumors, and treated with either vehicle or mirdametinib for 4 months, and then had everybody off treatment for 3 months, and then looked at the tumor size. And you can see that individual mice that were treated with mirdametinib had a relatively smaller tumor volume than those who had not been. Obviously, everybody had been off treatment for a while at that point. Importantly, though, in the bottom right, even after 3 months off treatment, those that were treated with mirdametinib had a significantly lower Ki-67. So some amount of the anti-tumor effect was residual even after being off treatment for 3 months in the mice. This is from a later experiment published by Jessen and colleagues that treated mice with a growing concentration of mirdametinib compared to control, and looked at tumor volume over time. And you can see tremendous tumor shrinkage. 0 is no change at all. Anything less than 20%, meaning that the tumor shrank 20% by volume. In humans, we call that statistically significant. So a very large proportion of tumor shrank more than 20% in this. So this really began to lay the preclinical groundwork for use of MEK inhibitors in the clinic for NF1-associated tumors. So Selumetinib is another MEK inhibitor and really came to the forefront as these things work. A variety of factors play into which drug you use in your trial, as we all know. So the NCI began looking at Selumetinib in a phase 1 study in children. I told you children tend to have faster growing tumors, and so this is the population that was targeted first. And looking at 3 different dosing levels, again, 20% volume reduction being considered significant shrinkage, they reported a 71% response rate in tumors in plexiform neurofibromas in children. Now, this being a phase 1 study, they did look very closely at adverse events, and the dose-limiting toxicities included elevated CK, cellulitis and urticaria for some individuals, some amount of left ventricular ejection fraction reduction, especially in their highest dosing cohort, mucositis, and rash. So not an incredibly long list, although of course some important side effects there. This is an image from their New England Journal paper just showing the remarkable improvement in this child's disfigurement and ultimately gait as the tumor shrank over time. So following that, a phase 2 study of Selumetinib was again done in pediatric patients with inoperable plexiform neurofibromas. This was done at the NCI. In this study, they looked at 50 patients whose median age was 10, and some of them were progressive, 21% were progressive, 15% were non-progressive. They were still disfiguring and or impacting function. They just weren't growing at the time of enrollment. You can see that they enrolled individuals with tumors in a large number of regions in the body, and importantly, with a large number of complications. And this is critical as they looked at the outcome of the study to look at clinical outcomes as well as tumor shrinkage for these non-malignant tumors. Another case study here from their second New England Journal paper showing the drastic reduction in tumor size from a previously growing tumor after Selumetinib was begun. And then in working very closely with the FDA, and after many years of very thoughtful curation of natural history data, they went on to compare this single-arm phase 2 study against the natural history cohort with similar eligibility criteria, and showed a drastic improvement in outcomes in terms of progression-free survival for individuals. They went on to look at multiple clinical outcome measures, including quality of life indices. Blue is improvement, and you can see that the huge number of individuals had improvement in quality of life and pain. And then for each of the clinical characteristics of the tumor, a validated score was assessed as well, including range of motion, strength, FEV1 for those that were near the respiratory tract, and similarly saw an enormous amount of improvement across those clinical domains. Lastly, looking at a global impression of change, you can see that a large majority of both parents and children treated reported a global assessment of positive change with treatment with Selumetinib. So based on all of this, Selumetinib was FDA approved for children 2 years and older with NF1 and symptomatic inoperable plexiform neurofibromas. As I go on to talk about some more of the work, it's important to note that for FDA submission, they went back and had a blinded independent central review. And although they reported 70% response in their New England Journal paper, the secondary review showed 44%. Still an important, impressive figure, much better than we had before, but we'll have to compare against 44% as we continue to talk about this. Now, Selumetinib is obviously the next question is, can you use it in adults? The only published study we have is from Korea. This year in neuro-oncology, a study looked at 59 children and 30 adults with NF1 and plexiform neurofibromas, and has begun to find similar outcomes in terms of response across kids and adults. So at least early days would suggest that there's activity in adults with these tumors as well. There's also, oops, I don't know what I did there. There's also a study happening at the NCI for adults with plexiform neurofibromas with selumetinib. Now, mirdametinib is the MEK inhibitor I showed you in the mice originally. It is also in testing now. I'm showing you some data that was published in 2021 from a NF clinical trial consortium study where it was used in individuals 16 years and older. So this is primarily an adult population. And they found about a 40% response rate in that study, and compare that to the 44% FDA approved ultimately selumetinib data. This is their swim lane plot, and showing you when response actually began for those who did go on to have a partial response versus those who never had a partial response. So it's important to note that really most of these people were out that 12 months or more before they truly met the 20% volume reduction in their tumor. So our experience is increasingly that it's a long, slow-acting medication to get to response for individuals, and that staying on drug, as you can see from many of these, will continue to develop response, maximum response for some not even achieved at the end of 24 months. A larger study named ReNeu for mirdametinib studied 58 adults and 56 pediatric patients. They presented an abstract at the Global NF meeting last month in Brussels. There's no publication yet, but initially they've reported an overall response of 41% in adults and 52% in children. So across the class, we see probably some consistency with variability here and there in the different populations. Now, plexiform neurofibromas are not malignant, but they do carry the potential of developing into malignancy. There's an atypical type of tumor in between, largely associated with a CDKN2A loss for the atypical development, and then the malignant peripheral nerve sheath tumor, which I told you is the leading cause of NF1-associated death, goes on to have an additional alteration in either SUS12 or ED. Now, the intermediate tumor is currently called atypical neurofibromatous neoplasm of uncertain biologic potential, which is a mouthful, and is characterized primarily by increased atypia, hypercellularity, increased mitotic activity, strongly associated with CDKN2A loss, and really this should be considered a pre-malignant tumor, just like a polyp that needs to be removed in a colonoscopy. So we begin to really address these aggressively. Now, there is another terminology that's called a neurofibroma with atypia. These names overlap, but it's important not to confuse these because those actually have no malignant potential. And then if you progress through the atypical neurofibromatous neoplasm and all the way to malignant peripheral nerve sheath tumor, this is an incredibly bad actor. So the lifetime incidence is probably on the order of 10 to 12%. This is data out of the UK showing that the older you get, the more likely it is you'll develop an MPNST. Survival is pretty abysmal, unfortunately. This really remains sort of the white whale of NF1. So the 50% of people are passed away by about 3 years in this cohort of individuals. Some of that relates to early metastatic activity in this tumor. Some of it relates to the severe difficulty of complete resections in the same way that plexiform neurofibromas are difficult to resect because of their adjacency to large organs and vessels and so forth. The diagnosis of MPNST, it's worth noting, can actually be pretty tricky because non-malignant tumors in this space can be PET-avid. It's really, it takes some nuance to differentiate a a moderately PET-avid non-malignant tumor compared to a brightly PET-avid malignant tumor. And sometimes because these arise within a plexiform neurofibroma, it's going to be a cellular expansion within a tumor. So you'll see sort of a sea of mild hyperavidity with an island of severe avidity. And you can imagine that confirming your diagnosis becomes really challenging. You have to do targeted biopsies to make sure you're exactly in your hottest location. Some centers also will use ADC mapping to look for a low ADC suggestive of hypercellularity in those lesions, as well as an additional screening tool. Unfortunately, there's no widely effective therapy for MPNST. This is a list of some of the targeted therapies that have been studied over the years, targeting EGFR, VEGFR, c-KIT, and unfortunately, none of these have been positive studies to date. There are a good number of ongoing studies looking at EZH2, looking at immunotherapy, and even a measles virus vaccine study that are ongoing. But truly, this is, at least on the clinician side, one of the most feared complications and risks of of NF1 because of the difficulty in treating it. Okay, I want to move on to talk about some of the other tumor types and novel therapies that are under development in NF1. So cutaneous neurofibromas are the hallmark of the disease. It's named for these. And you can see in this incidence graph here, only goes through age 20, but by age 20, more than 80% of people will have cutaneous neurofibromas. Across the lifetime, it's more like 95% of people will have at least one cutaneous neurofibroma. These are soft, fleshy. They can come in lots of different shapes, sizes, and colors. I told you that we don't have a great phenotype-genotype correlation, so we don't know why some people get just a small handful, others get just tumors upon tumors on their skin. These can be exceptionally pruritic, and that can be really detrimental to quality of life. These can be incredibly painful in some cases, not surprisingly, especially where they inhibit wearing particular types of clothing or other aspects. Pathologically, these are spindle cell tumors with a lot of myxoid stroma. Fibroblasts and mast cells continue to play an important role here as well. We think that's a component of the itch that patients have, although there's really sort of mixed results with antihistamine as a treatment for the itch of these. Some people end up needing neuropathic pain medications to try to control that as well. Now, I will say that historically, physicians treating NF1 have really focused on the malignancies as a critical scientific endeavor. But it turns out that patients really care a whole lot about the non-malignant cutaneous neurofibromas. And so the response evaluation in neurofibromatosis and schwannomatosis cohort, Scott leads, has done a lot of work engaging with patients to better understand what is important to them. And so these are just a couple of the published surveys. How much does each feature of your raised cutaneous neurofibroma bother you physically, cosmetically, or emotionally? And blue and orange are strongly agree. You can see that people are really impacted by their appearance, by the location of tumors, by the number and size of tumors. And then when we ask, I would prefer a scar instead of a cutaneous neurofibroma. I would prefer skin color changes instead of a cutaneous neurofibroma. People are happy to accept those instead of the tumors. So people are really interested in getting rid of these tumors however they can. The last thing here is using the Skindex, which is a very well validated dermatologic quality of life questionnaire that has domains in physical, emotional, and functional outcomes. 100 is very impacted, 0 is not impacted. And you can see that across individuals with NF1, and cutaneous neurofibromas. Emotional skin dex score is actually the highest of all of these. So this is truly distressing for many patients. Those who have facial neurofibromas tend to have a much higher skin dex score. And the number of cutaneous neurofibromas, not surprisingly, aligns perfectly with the overall skin dex score. So all of this highlights the critical need to focus on these tumors. And so based on the MEK inhibitor utility in plexiform neurofibromas, there's a lot of focus now going into trying to use MEK inhibitors for cutaneous neurofibromas. The challenge is there are some real adverse effects that we talked about in terms of cardiomyopathy risk and rash and so forth. And so trying to balance the risks of MEK inhibitor with the potential utility in cutaneous neurofibromas. Now a topical cream has been made. The idea being that there's high dermal penetration with this cream, but very rapid metabolism so that the systemic uptake and therefore the systemic side effects are quite minimal. So this is a look at the phase 1 study for this NFX-179 gel, where you can see that compared to vehicle, the gel at increasing concentrations reduces phospho-ERK expression, similar to what I showed you in the mice for their MPNSTs. And then looking at the mean change in tumor volume, you can see that higher concentrations of the gel lead to increased tumor shrinkage and volume reduction in more than 50% volume reduction increases across the different doses. So from the phase 1 study, a lot of great safety data suggesting incredibly low uptake and some early clinical responses. This did not translate well. I'm sorry for that. I pulled this data from the abstract that they presented at the Global NF conference last month. Now a phase 2B has been completed. And what you can see on the top is the percent of responders in volume. They looked at 2 different concentrations this time, and 44.2% of tumors responded by volume at the highest concentration compared to 34.5% with the medium. And then the vehicle was 24%. And then when they looked at the height of tumors, which is an ongoing question, what is the right way to measure these? They had about 40% of tumors responded with the high dose compared to 23%. So a lot of promise for topical MEK inhibition, potentially for shrinking individual cutaneous neurofibromas. It's also an ongoing randomized trial here at MGH, looking at a few different modalities. Deoxycholate injection, which essentially is a saponification tool for fatty cells, compared to a couple different lasers, alexandrite and 980 nanometer, compared to radiofrequency coagulation. Patients with more than 6 cutaneous neurofibromas are offered one treatment as they hear about them and what their differences is, or they're invited to randomize and do multiple treatments. And so have treated patients with up to 4 modalities based on region of their body. And so as you can see across those, looking at mean percentage change in tumor size, we're seeing some improvement across all of these, probably some higher level of clinical improvement or volume shrinkage between the deoxycholate and the alexandrite laser. A lot of the work that's going on with this now is trying to make these as comfortable as possible. Patients are, as we saw from surveys, willing to undergo a lot and willing to have scar tissue and so forth, but especially with laser work, Dr. Anderson and colleagues in the dermatology group spend a lot of time making them as clinically tolerable as possible, using cold techniques, using suction techniques, and so forth. Okay, the last tumor type I just want to talk about is optic pathway glioma. This is primarily present in children, as I showed you earlier. About 15% of children with NF1 will develop an optic pathway glioma. They may present with vision change, headache, proptosis, precocious puberty, depending on where in the optic apparatus the tumor arises. But importantly, probably most of these dissipate without any intervention. And so it's really a bit of a conundrum in our field. What's the right amount of screening? And when you identify a tumor, who needs to be treated? And so because the biggest fear for an optic pathway glioma is vision loss, one of the biggest fears, I should say, is vision loss. And because most children with these tumors may not require any treatment at all, it may dissipate and even shrink over time, the current paradigm is really to screen vision rather than MRI scans. And then if we identify an abnormal vision exam or the vision changes over time, then we scan with an MRI to look for tumor. This is one retrospective study looking at NF1 optic pathway glioma cases that were observed following that sort of natural history versus those that ended up requiring chemotherapy treatment. And you can see that in the observed category, those whose imaging status compared to the first scan improved, only 5% of their vision actually went on to get worse. Whereas those who had a stable MRI scan over time, 45% of their vision remained stable. So observing alone was perfectly fine for their vision over time. Obviously, people had more aggressive tumors if they ended up requiring treatment, but as comparing that to imaging status compared to the first scan, those who had a response, their tumor shrank. Their vision 7% improved, 9% stayed stable, 25% worsened. So if you get to the point of requiring chemotherapy, even if your tumor shrinks, your vision may worsen. So there may be some disconnect between tumor size and visual function, and a bad acting tumor, even though we can stabilize its size or shrink it, we may not be able to fix the visual component of it. So there's a lot of work that's being done to try to decouple the information about the visual function and the tumor size to figure out who needs treatment when. Now, not surprisingly, MEK inhibitors are beginning to being looked at in these tumors as well. This is looking at Selumetinib in a study of recurrent low-grade gliomas, not only in NF1, but those that were NF1 related are colored here in this yellow. And you can see that in this relatively small study, they did see some partial responses where there was true tumor shrinkage on scans for several of the patients, but not all patients with NF1 associated low-grade gliomas. There is an ongoing study of Selumetinib in children with recurrent optic pathway gliomas as well that we're anxiously awaiting results for. This is just a case from my own clinic. This is an adult who had a very late optic pathway glioma that's pretty unusual. We treated with Selumetinib. And you can see, first of all, that the enhancing pattern from before Selumetinib to after improved tremendously, although still some mass effect from non-enhancing tumor. But importantly, her visual function improved from 2100 to 2025 in the affected eye, and some of her field loss actually improved as well. So true radiographic and clinical improvement can be seen in these patients. The last sort of interesting idea is lamotrigine, which is being looked at. This is based on data showing that midkine is a protein that is closely associated with optic pathway glioma growth and with the neuronal function within an optic pathway glioma. So a big screen was done looking at seizure drugs as to which may reduce the neuronal function through reduction of midkine. Lamotrigine sort of came to the top of the list there. And so testing it in mice, they were able to identify that the retinal nerve fiber layer thickness improves and optic pathway glioma size reduces over time, Ki67 reduces. So there's some interesting approach to targeting the neuronal aspects of optic pathway glioma as well. a new pan-RAF inhibitor, tovorafenib, was FDA approved about 2 months ago. And so, we're currently targeting MEK here, but there are certainly cases of resistance that have been identified, and we didn't talk much about that here. So there's a lot of early discussion on whether working upstream as a pan-RAF inhibitor may be beneficial for those that develop resistance. There's also some ERK inhibitors in production as well that will be coming soon. So a lot of promising work happening. I'm going to talk for just a couple minutes about guidelines, which is another important piece of NF1. There are a handful of publications with recommended best care for NF1 that are not strongly based in data because we don't have any data. So this is sort of expert consensus. This is a long list of those individual recommendations, such as MRI is preferred over CT scanning to evaluate a neurologic deficit. Blood pressure should be recorded at least once a year, these sorts of things. We performed a survey of NF clinicians and asked, do you agree with these recommendations, just for a broad look? And you can see that there's a wide variety. Some of them are very strongly agreed across the entire community. Some of them actually had relatively low levels of agreement. So, when the small group of people got together to write this, it may not have been representative of the entire NF population and practice patterns, for instance. We then went on to look at patient care, and we surveyed patients in the NF registry and asked about 6 individual types of care that were recommended: blood pressure measurement annually, education about family planning, scoliosis screening, education about MPNST, and skin exam. And looked at the number of individuals who received those. And you can see that a relatively small proportion of individuals got some of those recommended care aspects. Looking at them as sort of a cumulative thing, only 8% of adults got all 5 of the guidelines that we looked at. Only 23% of kids got all 5 of the guidelines we looked at for kids. So really the level of agreement among clinicians may not actually be translating well to patients. We asked why, and so one thing that is contributing is whether a patient makes it to their NF clinic in the past 3 years or not. So if they're not going to an NF clinic, they're not getting their guideline-driven care. If they saw them within the past 1 year, they're getting their care more frequently. Seeing a neurologist helps if you're an adult. Unfortunately, your race and ethnicity does end up playing a component in the likelihood of you receiving guideline-driven care, and so does your insurance, where commercial insurance and Medicare tend to get better care. And so really, we've thought a lot about how do we begin to address this and disseminate guidelines. This is the problem. There's very limited access to NF care. Each red dot is a NF center of excellence that's part of the clinical care network. And you can see that huge swaths of the country just have no access whatsoever. Green dots are individual patients in the NF registry. So there's a big mismatch. And if we look at how far does an individual with NF have to drive, on median, they have to go 161 miles to get to their closest NF clinic. Obviously, that's much further if you live out west. So some of the things that are underway here, first of all, there's a multi-center group that's looking at the current care recommendations and really trying to identify opportunities for evidence development so that we can begin to work toward really guidelines rather than consensus recommendation. There's a pilot study currently funding 2 new adult clinics with mentorship to build more adult clinics and provide more access. And then lastly, Vanessa Merker and Scott Plotkin are leading this effort through a big federal grant through the Corey to develop a website for patients who can't make it to an NF clinic. So a patient would go onto a website and fill out a questionnaire about their NF. This is adapted from Brian Scotko's Down syndrome to you clinic. The website generates personalized care recommendations that you share with your primary doc, and hopefully together you work to get the guideline-driven care, even though you can't make it to an NF center. So, all right, last slide. Selumetinib is the only FDA-approved therapy in NF1 for children with inoperable plexiform neurofibromas, but there are a lot of additional promising things coming down the pike for plexiform neurofibromas, for cutaneous neurofibromas, MPNSTs, optic pathway gliomas. Access to NF clinics is limited, yet is so critical. Doing everything we can to optimize access, but also to make guidelines as clear and data-driven as possible and disseminate them in novel ways for people who can't make it to NF clinics is going to be so important to make sure that everybody has good care. That's all. Huge thanks to Scott and Vanessa. Ina Lee sadly left MGH out last month, but has been such a phenomenal scientific collaborator. And Christina Orrs, our NP, who helps do everything in the clinic, and to everybody else here. So thank you very much.
Listen, first of all, thanks for the magnificent talk. We the brand to the word brand jobs, really covering from vacancy. Also, thank you, Scott, for mentorship and starting all this, but it's amazing the shift from having just NF in a board exam, the right exam, and all the diagnostic treatment. Also want to thank, I have a question, but I also want to thank you for your leadership in NF1, but also for the entire group of neurologists in the country for your advocacy in DC, for leading all this American Academy of Neurology advocacy with the lawmakers and the politicians. So,
Thank you.
I was going to ask you what kind of coffee you drink, because the color is all good. It must be a very dark roast or the IV fusion. The question is related to age phenotype. And you touched upon this in the early parts of the talk. But have you discovered why? Is it a hormonal? Is it a cell timeline? Or how do we make peace that we don't understand this in whether targets are related to that?
Thank you for your kind words. I think for Zoom, I'm just going to repeat the last part, which is Marcelo asks about the timeline of clinical expression of NF1. And I think that we don't really know. The hypotheses include environmental factors contributing to the phenotype and the phenotype over time. Hormones have been such an important component of the discussion, especially showing the natural history data of plexiform neurofibroma growth pre and post puberty. There's a lot of consternation as it relates to pregnancy as well. We see many women who talk about increased tumor growth, increased tumor number during pregnancy, but that also aligns in their lifetime with the time that non-pregnant women tend to have more tumors arise and more tumors grow. And so it's really been hard to suss out the contribution of hormones compared to natural history. And then I think, as it relates to malignancy, the risk of all malignancy increases with age, and that probably relates to, normal pathogenic variants that we pick up, not normal, but pathogenic variants we pick up here and there through exposure to UV, to chemicals and so forth. And so I think that's probably a contributor to why the MPNSTs, the breast cancers, these things tend to happen in the older adults. But the earlier timeline, I would love, if you have theories, I would love to hear them. Kevin.
That sounds great. So in the old days, a young kid didn't need diagnostic criteria, clinical criteria, the recommendation of all this way to examine every year. But it's fine, but it's a little bit concerning for the clinician, for the family. Is the recommendation now to set a diagnostic clinically to get a sequence of it?
That is the idea behind the new diagnostic criteria. It has historically been challenging to convince insurance companies more than anything for the need for NF1, but by including that in the diagnosis, by trying to uncover additional genotype-phenotype correlations, the goal is that everyone gets sequenced so that we can best inform the discussion. One other thing that you sort of didn't say, but and neither did I. Plexiform neurofibromas, in the old days, you'd watch them, and there's a lot of question now that we have drugs for them. When do you treat? There is an ongoing randomized study now looking at the idea of early intervention for a tumor that is not causing problems today, is not growing today, but it's in a really crummy location that if it were to grow and cause problems, the kid would be in trouble. So sort of a proactive trial is underway as well at the NCI. Okay. Thank you very much.